Hey, Pediatric crew, brace yourself for tiny chaos. Welcome to a deep dive where we unpack the fascinating, sometimes bewildering world of toddlers and preschoolers.
That's right. We're taking a deep look at the essential building blocks of development, those surprising safety risks, sometimes lurking right in plain sight,
Yeah.
and how to navigate tricky behaviors, hit those crucial milestones, and, importantly, what this all means from a nursing care perspective.
Our material today is, well, it's a really comprehensive guide. I think of it like a go-to professional resource for really understanding this age group.
Hmm.
And our mission is pretty simple. Pull out the most important insights, the practical tips you actually need, and maybe even, a few surprising facts to help you understand and navigate these absolutely vital years.
And we'll be focusing on children roughly aged, 1 to 5 years old?
Yeah.
Often splitting it into the toddler, so 1 to 3, and preschooler 3 to 5 phases. Because, let's be honest, anyone who's spent time with them knows.
Yeah.
A 1-year-old is a very different creature from a 5-year-old.
Totally different. So let's jump in.
Okay.
Let's kick things off with growth and development. I mean, it's truly amazing how fast these tiny humans go from wobbly steps and maybe a word or two
Uh-huh.
to running, talking, nonstop question-asking machines. The guide gives us some key theoretical lenses to understand what's driving these big changes, starting with toddlers, ages 1 to 3.
Yeah, and what's fascinating here is seeing how these theorists, really capture the essence of this period. Erickson, for instance, he highlights autonomy versus shame and doubt.
The me-do-it stage.
Exactly. That's the core push for independence, wanting to do things themselves, control their own bodies, whether it's around like toileting or choosing what to eat.
Right?
And success in asserting this independence in healthy ways, well, that's critical for building their confidence.
Right, that foundation. And Piaget describes this as the pre-operational stage. This is where you see that magical thinking, the idea that their thoughts can actually influence the world, and egocentrism, which isn't being selfish, right?
No, not in a moral sense. It's literally the inability to see things from someone else's point of view. Everything really is about them in their little world at this point.
Gotcha.
Then Freud adds his perspective with the anal stage, focusing on pleasure related to bowel control, which ties right back into that autonomy struggle around potty training.
Okay.
And Kohlberg places them in the pre-conventional moral reasoning stage, basically. They follow rules primarily to avoid punishment, not because they grasp abstract right or wrong yet.
And
It's all about consequences for them.
okay, consequences, that makes sense. So understanding those underlying drives helps frame the milestones, right? How it actually shows up physically.
Yeah,
The material provides great examples for toddlers. Motor skills just explode.
they really do. Walking alone often happens around maybe 15 months, and running, climbing stairs while holding on by about 21 months.
Building is huge too, isn't it?
Oh, yeah. 4 or more blocks by age 2, 6 or more by age 3. They're kicking a ball, really getting the hang of running and jumping by age 2.
There's that memorable line from the source, 3 years to 3 wheels.
Yeah. Tricycle readiness often hits around age 3. And turning a doorknob, that's a surprisingly significant fine motor achievement, showing that increased dexterity.
And language development is equally dramatic. Pointing, recognizing names, theirs and others.
Understanding so much more than they can actually say, especially at first.
Exactly. And the sheer word count jump is staggering. Maybe 5 words at 12 months to, was it 50 by 18 months?
Yeah, a huge leap. And then sentences start to emerge. Simple 2-3 word phrases by age 2,
Right.
evolving into 2-3 sentences by age 3. That's also when they start using personal pronouns like I, me, and you.
Yep.
More complex communication.
Cognitively, they're finding hidden objects. That object permanence is solidifying. They're starting to identify and sort colors and shapes, getting into make-believe play.
Scribbling. And showing a definite hand preference often starts here, too.
Socially and emotionally, it's all about imitation, isn't it?
Totally. Imitating everything you do. Developing self-awareness, they recognize themselves in the mirror. They're starting to enjoy being around other kids, though. As the source notes, it's often parallel play at first.
Ah, right, playing near each other, but not really with them yet.
Exactly. Kind of in their own bubbles, side by side. Affection definitely appears alongside, well, the inevitable defiance.
Oh, yes, defiance.
And separation anxiety is really common, often peaking around 10 to 18 months, but typically fading by about age 2. And if a new sibling arrives, sibling jealousy is a very real part of this picture.
Definitely something to watch for. The guide also touches on fostering self-care, which is such a crucial component of nursing care education for families. By age 2, they can follow simple instructions.
Mm-hmm. And we really need to encourage their participation in simple tasks, offer limited choices that gives them that sense of control Erickson talks about.
Good point. Not overwhelming them.
Exactly. And emphasize the power of routines and rituals.
Why are routines so important at this stage?
They provide security and predictability in what can feel like a rapidly expanding, sometimes overwhelming world for them. It helps build that autonomy successfully, without constant battles.
Okay, that makes a lot of sense. Predictability equals safety for them.
Now, let's shift gears a bit and look at the preschoolers, ages 3 to 5. Their theoretical stages kind of build on those toddler years, right?
They do. Erickson's focus shifts to initiative versus guilt. They're asserting their power and control even more now, taking initiative in activities, making decisions.
So exploring more.
Exactly. Encouraging this exploration helps them develop a sense of purpose. But being overly critical or, controlling can lead to guilt about their own desires and actions.
That's a delicate balance for caregivers.
It really is. Piaget still has them in the pre-operational stage, so that magical thinking and egocentrism persist, though you start to see glimpses of more logical thought as they get closer to 5.
Okay, so still thinking magically, but maybe starting to question it a bit. Sort of. Freud's phallic stage is next, centered on the genitals. Childhood masturbation is common exploration at this age, and they might show increased interest in the opposite sex parent. It's normal curiosity.
And Kohlberg, still focused on rules?
Still on that pre-conventional stage, yeah. Driven by obedience to avoid punishment, but maybe starting to think about rewards too. If I do this, maybe I'll get that.
Okay, so what about their milestones? The physical ones for preschoolers show a huge jump in coordination and capability.
Huge. By age 3, they're often dressing and undressing with maybe just a little help, managing stairs without holding on.
Drawing gets more complex too.
Oh yeah. Squares and circles around age 3, then triangles later. Using utensils and cups pretty well by 3. By 4, they're hopping, standing on one foot for like 5-10 seconds.
Wow.
Throwing overhand, catching a bounced ball, that coordination is really coming along.
And drawing people.
Stick figures become more detailed. More than 2 parts by age 4, then adding bodies. Using scissors proficiently comes around age 4 too.
And by 5, what are we looking at?
By 5, often brushing teeth and managing the toilet all by themselves. Skipping, maybe even tackling a bicycle or swimming lessons. It's a big year for motor skills.
Language just explodes too, right?
Yeah.
Much more complex.
Definitely. Speaking clearly enough for strangers to understand, most of the time by age 5 is common. Sentence length grows 3 to 4 words at 3, 4 to 5 words at 4, 5 or more words by 5.
They start telling stories.
Using future tense, rhyming. Later, they can also state their full name and address. But here's a key point from the source. Their interpretation is still very concrete and literal.
So idioms or sarcasm might go right over their heads.
Completely. You have to choose your words carefully and mean what you say, literally.
Cognitively, what's happening?
They can recall parts of a story, count to 10. Though the guide knows they might not grasp the true concept of numbers yet, it's often rote memorization.
Okay.
Identifying 4 or more colors. Time concepts are just starting to emerge, like today, tomorrow. Understanding same versus different.
Then imagination is huge now.
Paramount. It fuels all that dramatic play, and of course the famous persistent why phase.
With the why phase, every parent knows it well.
Socially and emotionally, they're becoming more independent and visibly proud of their abilities. They desperately want to do things by themselves.
Right.
They want to please and be like their friends. This is where you see a shift into associative play.
So playing with others now.
Yeah, truly playing with them, sharing ideas and toys, though they still need guidance on navigating conflicts and sharing.
They start negotiating problems a bit, but still struggle differentiating reality from fantasy, right? That's where the monsters under the bed come in.
Exactly. Monsters are very real to them. They become more aware of gender and racial differences and continue exploring their bodies, including genitalia again, normal curiosity.
Okay.
They can be a bit demanding, but also incredibly eager to help. Sibling jealousy often persists, and they develop a really strong sense of body integrity. They get very sensitive about anything happening to their physical self, like shots or even minor scrapes.
This leads to a clinical judgment point the source makes about praise.
Yes, really important. Praise the action or the effort. Good job putting your shoes on, rather than labeling the child good boy or good girl.
Why is that distinction important?
Because of that magical thinking. They might internalize things differently. Like if they get sick, they might think it's because they were bad. Praising effort focuses on what they can control.
Gotcha. And related to that magical thinking and fears, the fear of the dark is so common.
Very common. And the guide suggests practical steps. Using night lights, maintaining really consistent bedtime routines. These provide comfort and security, addressing the fear through understanding their developmental stage. Simple, effective strategies.
Good practical advice. So, with all this amazing complex development happening, how do professionals like nurses actually assess these dynamic little beings? The guide provides a pretty clear roadmap for the nursing assessment.
It really does. It always starts with a health history. You get
Mm.
the chief complaint, why are they here today? Then family and medical history. Any illnesses, hospitalizations, immunizations, screening results, medications, allergies. A review of systems focusing on basics like eating, sleeping, elimination.
And social history, too, right? Living situation, daycare, behavior patterns.
Absolutely. Getting that comprehensive picture is the foundation before you even lay hands on the child.
And the physical assessment itself, it needs a strategic approach, doesn't it?
Definitely. The source advocates for a head-to-toe method, but importantly, moving from least invasive to most invasive areas.
So maybe listen to the heart and lungs before looking in the ears or mouth.
Exactly. And critically, save any painful or scary parts for the very last. This helps build rapport and cooperation, which is half the battle sometimes.
Measurements are obviously key.
Non-negotiable. Standing height for older toddlers and preschoolers. Recumbent length, lying down. For younger toddlers, because of that common lordosis, that natural inward curve of the lower spine you often see. Weight with minimal clothing. BMI starting over age 2. Head circumference is routine under 2 years, and maybe later if there are specific concerns.
And vital signs, they're different from adults, need those age-specific ranges. The guide really emphasizes using the right cuff size for blood pressure.
Yes. Too big or too small gives you totally inaccurate readings. It matters.
And there's a critical component mentioned in the material about childhood obesity and hypertension.
Right. While the text notes a specific review didn't find a definitive link between pediatric hypertension and adult cardiovascular disease later on, the importance of accurate BP measurement and monitoring according to your facility's policy remains vital clinical practice. We still track it carefully.
General appearance gives you immediate clues, right? Even before you start the hands-on exam.
Definitely. Cleanliness, how they're dressed, their overall behavior, any obvious issues with hearing, vision, or speech. How do they interact with you and their caregiver? Nutritional status, looking at things like hair quality, weight, skin dryness. Then the systematic head-to-toe checks all the body systems. Okay, now here's where it gets really interesting and directly impacts how we provide care. The guide highlights this critical component, discussing the fundamental physical differences between children and adults. This is why our assessment techniques and interventions have to be different.
This is so important. Their heads are proportionately larger, right? Which increases fall risk.
Exactly. And they have a greater surface area to weight ratio. That impacts temperature regulation, fluid loss.
Makes them more vulnerable to dehydration and hypothermia.
Precisely. And their airway differences are profound. Larger tongues, more soft tissue.
So the airway is shorter, narrower, more elastic, much more collapsible.
Yes. All of those. Their chest is more pliable, making them more susceptible to the impact of blunt trauma on internal organs. Their weaker abdominal muscles contribute to distension, and the fact that they are primarily belly breathers. You watch the abdomen rise and fall, not the chest as much.
Higher metabolic rates, too, meaning they burn through fuel and fluids faster.
Right, which means higher fluid requirements relative to their size.
Yeah.
And their total blood volume is higher proportionally. These aren't just textbook facts. They are potentially life-saving points that dictate how we approach things like respiratory distress, fluid resuscitation, even medication dosing.
Absolutely critical. And clinical judgment plays a huge role in just getting through the assessment while keeping the child comfortable. The source has good tips for that.
Yeah, practical things. Let the child choose which finger for the pulse oximeter or which arm for the BP cuff.
Giving them some control.
Right. Demonstrate on the caregiver first. Maybe call the BP cuff a tight hug instead of something scary.
Yeah, I like that. Staying physically close to the caregiver, assessing toddlers in the parent's lap whenever possible.
Protecting a preschooler's modesty, getting down to their eye level so you're not towering over them, and using specific praise like, "You held your arms so still." These are all key strategies to make it less scary and more effective.
And the specific techniques, what are we looking for?
Visually, you're scanning for labored breathing. Are they using accessory muscles? What's their position of comfort? Looking at the skin for bruising, rashes, lesions.
Auscultation listening.
All right, clear lung sounds or adventitious sounds like wheezing. Listen to their neck for stridor or snoring. Listen to the heart apical pulse for a full minute. Check for bowel sounds.
Palpation, gently feeling.
Feeling the abdomen. Checking pulse's quality. Are they equal bilaterally?
Yeah.
Upper and lower extremities. Feeling the scout for fontanelles, which should be closed by age 2.
There's that great clinical judgment tip in the guide for assessing breath sounds in a scared kid.
Oh, the blow out the candle one. Yeah, have them pretend your finger is a candle and try to blow it out.
Makes it a game.
Exactly. It often gets you a deeper breath without a fight.
Smart. Finally, tracking growth requires using those assessment charts, the CDC ones.
Yep. For length, weight, head circumference, weight for stature. And the material highlights recommended developmental screening times 9, 18, and 30 months are key points. It lists tools like the ASQ, the Ages and Stages Questionnaire, or the DDST-2. These screenings are so critical for catching potential delays early when intervention makes the biggest difference.
Early detection is everything. Okay, if assessment tells us where they are developmentally and physically, then safety is all about protecting them as they explore. This next section dives into a really serious area. The guide starts with a sobering fact from the CDC.
Yeah, it's stark. Unintentional injury is the #1 cause of death for all children in the United States.
Number 1, that's huge.
And a key insight from the material is breaking down the leading causes, specifically for the 1 to 4 age group. Injury deaths are led by accidents, things like drowning, falls, burns, suffocation,
Right.
but also include congenital malformations, malignant neoplasms, cancers, assault, homicide, and heart disease.
And for non-fatal injuries in this age group, what are the most common culprits?
Falls are huge, being struck by or against something like furniture tipping over, and bites or stings.
And focusing on deaths again, the guide highlights drowning specifically.
Yes, drowning is the leading cause of injury death for kids aged 1 to 4. And falls and poisonings also have their highest incidence in this age range. It really tells you where the biggest risks are concentrated for toddlers and preschoolers.
So in a clinical setting, what are the direct nursing interventions for safety?
Always keeping side rails up on cribs and beds. Never leaving a crib side down even for a second if you turn your back. Meticulously checking equipment, IV cords, monitor wires, suction tubing for anything that could cause entanglement.
Minimizing attachments too, right? To prevent choking or suffocation hazards.
Absolutely. And always checking the temperature of any water, food, or drinks given to prevent burns. It seems basic, but it's crucial.
The guide also touches on exploring signs that might need a child protective services referral.
Right. Acknowledging that unfortunately abuse is a safety risk. Nurses are mandatory reporters. We have a legal and ethical duty to report suspected abuse or neglect.
Okay, so let's talk caregiver education for safety at home. The list is extensive because the home is just full of potential hazards for these little explorers. Burns, for example.
Huge risk. Keeping hot liquids, coffee, tea, soup away from edges, and never holding a child while drinking something hot. Using back stove burners, turning pot handles inward. Securing small hot appliances like irons or curling irons way out of reach.
And the hot water tank temperature?
Set it to a maximum of 120 degrees Fahrenheit, that's 48.8 Celsius. Any hotter significantly increases scald risk. And always, always check food or liquid temp before serving it to a child.
Falls prevention, what are the key points there?
Safety gates, properly installed, especially hardware-mounted ones at the top of stairs. Securing heavy furniture like TVs and bookcases to the wall. This is a surprisingly frequent and serious injury source. Keeping windows closed and locked screens offers zero protection against falls.
Good reminder about screens.
Yeah, and never leaving young children unattended on elevated surfaces like porches, decks, or balconies.
Other home hazards seem endless.
They really do. Keep all medications and poisons, and this includes things like cleaning supplies, cosmetics, hand sanitizer stored high up, locked if possible, and always in their original containers.
Have the poison control number handy.
Absolutely. 1-800-222-D222 posted somewhere visible. And the guide makes a great point. Child-proof tops are a last defense, not the primary prevention strategy. Don't rely on them solely.
Okay, what else?
Cleaning up old, peeling paint because of lead risks. Checking toys for small parts. They could be choking hazards, especially for kids under 3. Buying age-appropriate toys. Throwing away broken ones immediately. Securing loose cords from blinds or electronics, a strangulation risk. And staying updated on recalled items.
Eating safety is another big one.
Yes. No eating and playing at the same time increases choking risk. Cut food into small, bite-sized pieces, especially for toddlers. Avoid those high-risk choking foods listed in the source. Nuts, whole hot dogs, hard candy, popcorn, whole grapes.
And the source specifically calls out coins and latex balloons, too.
Major choking hazards. Just keep them away entirely. And for water safety at home, never leave water standing in tubs or cleaning buckets. Close bathroom doors. And the absolute rule, never leave children alone near any basin of water, tub, bucket, pool, toilet, not even for a second. Drowning happens silently and quickly.
The guide highlights some specific dangers that might surprise people. Hand sanitizer.
Yet while a tiny lick is probably okay, ingesting more is risky due to the high alcohol content. This became a bigger concern with the increased use since COVID-19. Keep it stored like any other poison.
Medication's huge risk.
Huge. The guide is crystal clear. Never tell a child medicine is candy. Ever. Keep it completely out of reach. Remember, safety caps are just a backup. And caregivers absolutely must be shown how to measure liquid doses accurately using a proper dosing syringe or cup, not kitchen spoons.
And those colorful laundry detergent pods?
Oh, these are a major hazard highlighted in the source. They look like candy, but contain highly concentrated toxic chemicals. Ingesting them, or even getting the contents splashed in the eyes, can cause serious health problems.
There were stats on that, right?
Yeah, pretty alarming. Over 72,000 calls to poison control between 2012 and 2017 involved these pods, and a staggering 91.7% of those calls were about children under 6 years old. Keep these absolutely locked up and out of sight and reach.
Wow. Okay, what about outdoor safety?
Just as critical. For swimming areas, ensure home pools, ponds, or lakes are completely fenced with self-latching gates. Never leave a child unattended near water, even if they know how to swim. Use Coast Guard-approved life vests. Avoid leaving toys floating in the pool area that might tempt a child to go near the water unsupervised.
Playgrounds.
Unfamiliar playgrounds carry higher risks. Teach basic rules like no running near swings or ropes, no putting heads through bars. And the source is emphatic. No trampolines at home. The risk of serious fractures and spinal injuries is just too high.
Okay, no trampolines. Street safety.
Teach crosswalk rules early. No running into the street after a ball or toy. Never playing in the street itself.
And vehicle safety both in and out of the car.
Outside the car, always wear a properly fitted bicycle helmet and reinforce that bikes belong on sidewalks or paths, not streets, for young children. Inside the car, always use an appropriate child safety seat or booster seat correctly installed. Place children in the back seat, ideally until age 13. These aren't just suggestions. State laws mandate these things for very good reasons.
The source also includes a note about evacuation plans under safe and effective nursing care.
Yes, it's important for families to have a practice plan. Children might hide during emergencies like fires. The plan needs alternative exits from the home and a designated safe meeting place outside. This applies to any emergency, really, not just fire.
And finally, related to safety, there's the critical component of child abuse assessment.
Yes, something nurses are directly involved in. The source is clear. Nurses are mandatory reporters. We cannot keep secrets about suspected abuse or neglect. We have a legal obligation to report.
What are some red flags to be aware of?
Be vigilant for non-typical bruising, considering the location, like torso, ears, neck, symmetry shaped like an object, or bruises in different stages of healing. A history of multiple broken bones without a clear medical cause. A caregiver's story that just doesn't fit the injury or the child's developmental ability. Or multiple hospitalizations without a clear, chronic underlying illness. These are significant red flags that require further assessment and reporting according to policy.
Okay, critical information for sure.
So beyond those immediate safety risks, what about the big day-to-day hurdles that families of toddlers and preschoolers often face? The guide walks us through some really common challenges.
Potty training has got to be high on that list.
Definitely. And the source outlines key readiness signs, which is crucial. Don't push before they're ready. Look for things like having dry periods for a couple of hours, having predictable bowel movements, showing actual interest in the potty, or wearing underwear.
Being physically able to sit down and get up.
Right. Following simple directions. Showing unhappiness with being wet or dirty. And maybe even vocalizing the need to go, or telling you right after they've gone in their diaper.
And caregiver actions should focus on encouragement.
Absolutely. Practice sitting on the potty, maybe fully clothed at first. Teach good hygiene like hand washing afterwards. Explain front-to-back wiping for girls. Have boys start sitting down first. It's often easier. Use encouragement, praise, maybe small rewards or incentives, but never punishment or shaming for accidents.
And if the child resists strongly,
That's a key insight from the source. Strong resistance likely means they're just not ready. Back off. Try again later. And avoid starting during stressful times, like moving or the arrival of a new sibling.
Good advice. Separation anxiety is another big one.
Yeah, and it's a normal developmental stage, usually peaking around 10–18 months, but can certainly last up to age 3 for some kids. The fear generally lessens as they mature and understand you'll return.
What helps caregivers manage it?
Strategies involve distraction, making goodbyes quick and confident. Lingering often makes it worse. Practicing short separations at home first, staying calm and consistent yourself, and always reassuring the child that you will come back.
Tantrums. Oh boy. The guide spends some time on tantrums.
Because they're so common, especially between ages 1 and 4, they're basically intense, overwhelming expressions of anger and frustration because they lack the language or coping skills to deal with big feelings.
What do they look like?
Whining, crying, screaming, sometimes hitting, kicking, scratching, biting, or even that scary breath holding.
And the triggers.
The source lists common ones: hunger, tiredness, discomfort, being overstressed or overstimulated, seeking attention, or sometimes underlying problems. Understanding the trigger can help prevent them sometimes.
So, caregiver actions. Staying calm is key.
Absolutely crucial, though incredibly hard sometimes. Stay calm yourself. Implement consistent, predictable consequences like timeouts, explained simply, and stick to routines, which provides that needed stability.
And there's hope. They decrease eventually.
Yes. A hopeful point from the source is that tantrums usually decrease significantly as language skills improve. When they can use their words to express needs and feelings, the need for those physical outbursts lessens.
Okay, good to know. Sibling rivalry also normal.
Very normal. The jealousy, the competition, the fighting, often over attention or dominance. Quarreling over toys, name-calling, tattling. It's all part of learning to navigate social relationships.
When should parents intervene?
Intervene in unsafe or truly destructive situations. Separate the kids calmly. Set clear, consistent rules. No name-calling, no hitting or pushing, no slamming doors. Actively try to avoid taking sides. Teach them how to express their feelings appropriately. Use your words. Tell them how you feel. And importantly, encourage kindness, sharing, and comforting each other when appropriate.
Let's move to nutrition. So fundamental for their growth and energy, toddlers have different eating patterns, right?
Yeah, they tend to eat more frequently throughout the day, sometimes like 7 small meals or snacks. They graze more. Preschoolers typically settle into more of a 3 meals plus snacks pattern.
A key takeaway seems to be avoiding pressure around eating.
Yes. Avoid large portions and absolutely avoid pressuring them to finish everything on their plate. This can override their natural hunger and fullness cues and contribute to obesity risk later on.
So let them self-regulate.
Exactly. Allow them to self-regulate based on their hunger. Your job is to offer healthy choices consistently, allow grazing throughout the day with those healthy options, and be prepared for toddler food jags, where they might only want 1 or 2 specific foods for days or weeks. It usually passes.
What about milk?
The source outlines the transition. Whole milk from ages 1 to 2, because the fat is important for brain development. Then transition to skim or low-fat milk after age 2. And support for continued breastfeeding is also important if that's the family's choice.
Protein needs are mentioned, and common allergens too.
Right. RDAs for protein are noted. And common allergens to be aware of include dairy, seafood, nuts, soy, eggs, wheat. Healthy snack ideas from the guide are pretty straightforward. Fruits, veggies, milk, yogurt, cheese, whole grain crackers, nuts, or peanut butter, if no allergy and appropriate texture supervision.
Serving sizes are smaller, obviously.
Roughly half an adult portion for 2 3-year-olds, aiming for maybe 1,000–1,400 calories per day. But again, let their appetite guide it. Encouraging self-feeding isn't just about nutrition. It builds crucial fine motor skills and reinforces that self-regulation.
Appetite fluctuates wildly, doesn't it?
Totally normal. Don't stress if they eat like a bird one day and a horse the next. They should transition from bottles to cups and be using utensils pretty well by age 2. Preschoolers might still struggle with sitting still for entire meals. Keep expectations realistic.
What are some common nutrition challenges mentioned?
Ensuring adequate iron and zinc intake is important. The guide lists RDAs and good food sources. Fostering healthy eating habits for the long term. Dealing with finicky or picky eaters, very common. Kids playing with their food. Sensitivity to textures and tastes. Those persistent food jags we mentioned.
And the big one, juice and sweet drinks.
Huge emphasis on limiting these. The guide recommends limiting 100% juice to just 4 to 6 ounces per day, maximum, and really stresses that water is the ideal drink. Sugary drinks contribute empty calories and increase risk for cavities and obesity.
And that leads us right into another critical health issue, the source highlights, linked so closely to diet: dental caries, cavities.
Yes, this is flagged as a serious public health problem. The prevalence in primary teeth is high. The source quoted 46.2%. That's almost half of young children.
And a major risk factor is drinking from a bottle throughout the day or night.
Absolutely. Constant exposure to milk or juice sugars bathes the teeth and dramatically increases cavity risk. It can also decrease their appetite for more nutritious solid foods. The American Dental Association recommends the first dentist visit by age 1 or within 6 months of the first tooth erupting.
The impact of untreated cavities is significant.
Huge. Pain, infection, difficulty eating and sleeping, problems with learning and concentration. It can affect growth, behavior, mood, even social skills. Plus, it's costly to treat.
And the source makes a powerful point about a potential link.
Yes, a potential relationship between severe, untreated dental caries and concerns about child mistreatment or neglect. It's something healthcare providers need to be aware of.
Prevention is key then. What are the main points?
Use the right amount of fluoride toothpaste, just a tiny smear, like a grain of rice, for kids under 3. Then a pea-size amount for ages 3 to 6. Start flossing gently once teeth are touching. And strictly limit juice and sugary drinks. Simple steps, major impact. Okay, rounding out this section, let's talk about fostering that growing independence we discussed earlier with Erickson's stages. It's something we need to actively encourage, but safely.
How do we do that?
It involves teaching them simple rules, responsibility, and safety awareness as they naturally want to explore more. Teaching them basic social skills, how to be a good friend, sharing, which is hard, being kind, using gentle hands instead of hitting.
Establishing routines helps too.
Definitely. Routines help them learn to do things on their own reliably, like tidying up toys before bed. Giving them simple, age-appropriate chores builds that sense of responsibility and contribution. Even helping set the table or put their clothes in the hamper.
And listening seems important.
Actively listening is vital. Using open-ended questions, getting down to their eye level to make eye contact, shows you value what they say, and encouraging them to participate in their own self-care bathing, dressing, providing assistance as needed, but letting them try first. These steps build competence and reinforce that autonomy they're striving for.
Building them up step by step. Okay, let's move on to a particularly challenging aspect of care for this age group: pain management.
Absolutely challenging. Assessing pain accurately is difficult because toddlers and preschoolers can't always articulate what they're feeling, where it hurts, or how badly. That ability to verbally convey pain really only starts developing around age 2. And even then, it's limited.
So caregiver input is important.
Very important. Always ask the caregiver's opinion about the child's pain level or behavior changes. But the source cautions us to be careful not to influence the child's response while doing so. Ask the parent separately if needed.
And a really critical point the source emphasizes: vital signs alone are not reliable indicators of pain in kids.
Exactly. Elevated heart rate, blood pressure, or respiratory rate are poor indicators of pain by themselves. Kids can have elevated vitals for many reasons: fear, anxiety, fever. We need to focus on observing your behaviors.
What kinds of behaviors should we look for?
Look closely at their facial expression. Is there a furrowed brow, a tight grimace, or maybe a concerning lack of expression, being really withdrawn? Their movement. Are they restless and agitated? Or are they withdrawing from touch, guarding a specific body part, wary of moving?
Vocalization, too.
Yes. It can range from being unusually quiet or moaning to a harsh, high-pitched, inconsolable cry. Irritability, changes in sleep or eating patterns, being difficult to console, these are all key behavioral clues that might indicate pain.
The source mentions several pain scales specifically designed for this age group.
Right, because they can't use the 0-10 number scale reliably. The FLACC scale is commonly recommended. It stands for faces, legs, activity, cry, consolability. It's observational and good for kids age 1 to 5, especially those who are preverbal or nonverbal.
And the Wong-Baker Faces scale.
That's the one with the cartoon faces showing different expressions from smiling to crying. It's generally recommended for ages 3 to 7, where the child points to the face that shows how they feel. Though the source does note, some studies question its reliability, specifically in kids under 5. They might just point to the happiest or saddest face, regardless of how they feel.
So use the most appropriate tool for the child's age and developmental level.
Exactly. And the crucial rule the guide stresses: when in doubt, assume pain is present and treat it. Don't let a child suffer just because they can't tell you clearly.
And always follow up, right?
Always. Evaluate and document whether your intervention whether it was medication, repositioning, distraction, or simple comfort measures, was actually effective in reducing the pain. Assessment is ongoing.
Medical play is mentioned as a useful tool here.
Yeah, it's a fantastic clinical judgment strategy. It helps you explain upcoming procedures using concrete terms they can understand. Let them handle safe equipment, maybe listen to a doll's chest with a stethoscope first, feel the BP cuff on their arm.
Demystifies it a bit.
Exactly. And importantly, it allows children to keep their comfort items like a favorite stuffed animal or blanket nearby during potentially scary or painful procedures. That security is huge.
There's another critical component highlighted regarding medication administration providing choices.
Yes, this is key. Never give children the choice of if they're going to take their prescribed medication. That's non-negotiable for their health. The choice should only be how they take it, like liquid versus chewable if both are options, or what they take it with, a small sip of water, juice, applesauce if compatible with the med.
Gives them that small bit of control.
Exactly. It respects their developing autonomy without compromising necessary care.
The source also briefly notes cultural competence.
Right. Pain expression and perception can vary across cultures, so be mindful that standard scales might not capture everything accurately for every child. Observe behavior carefully.
And finally, a nod to evidence-based practice regarding COVID-19.
Yeah, just noting that children hospitalized with COVID can experience pain symptoms like headache, sore throat, muscle aches, or abdominal pain. And reminding us to use both pharmacological interventions like acetaminophen or ibuprofen and non-pharmacological ones like ensuring adequate fluids, encouraging rest, using distraction, or simple comfort measures. A holistic approach.
All these challenges, developmental stages, and clinical considerations really underscore how much caregivers need our support. Nurses play such a vital role here.
Absolutely vital. In the hospital setting, that support includes orienting caregivers to the unit, the routines, the equipment, explaining procedures and the plan of care step by step every day.
Encouraging questions.
Actively encouraging questions and their involvement, helping them learn about their child's medications, names, doses, side effects, involving them in decision-making about their child's care as much as possible.
And emotional support too, right?
Definitely. Normalizing and reassuring them that it's perfectly okay and understandable to feel scared, helpless, anxious, or overwhelmed when their child is sick or hospitalized. And reminding caregivers that their own self-care is necessary. It's okay to take a break, go home for a shower, grab a meal. They can't pour from an empty cup.
So true. What about supporting caregivers at home? Equipping them for when they leave the hospital or clinic?
That means ensuring they have essential information. Make sure they have emergency phone numbers readily available. A clinic nurse line, the PCP's on-call number, poison control, that 1-800-222-1222 again, and of course, 911.
Educating them on common illness signs.
Yes, signs and symptoms of common infections like fever combined with cough, nasal discharge, ear pulling, or fussiness. Teaching proper home fever care, how to use a thermometer accurately, which type, which route, how to dose weight-based medications like acetaminophen or ibuprofen correctly.
Simple cooling techniques.
Right? Like dressing lightly, avoiding heavy blankets, offering cool fluids, but avoiding things that cause shivering, as that can actually raise temperature. And crucial dehydration prevention strategies during illness. Small, frequent sips of fluids, water, electrolyte drinks, clear broths, popsicles.
Diet advancement, too.
Yeah, starting with bland foods like the brat diet, bananas, rice, applesauce, toast, if there's vomiting or diarrhea, but quickly moving back towards a balanced diet as the child tolerates it.
Simple first aid education is also helpful.
Basic wound cleansing for scrapes, how to apply bandages correctly when it might be appropriate to use a topical antibiotic ointment, and critically, teaching them to recognize the signs of respiratory distress.
What are those key signs again?
Rapid breathing. Retractions where the skin pulls in between the ribs or above the collarbone with each breath. Nasal flaring. Using accessory muscles in the neck or shoulders to breathe, assuming a tripod position, leaning forward on hands. And hearing abnormal sounds like stridor, that high-pitched noise on inhalation, or wheezing, a musical sound usually on exhalation.
Mentioning things like using a cool mist humidifier or sitting in a steamy bathroom can sometimes help with croupy coughs, too.
Good point. And knowing when to call the primary care provider, PCP, is vital. The guide lists key scenarios. Any negative change in the child's condition, if they need immediate information or advice, if the child loses a developmental skill they previously had, regression, or simply if the caregiver suspects something is wrong, trust that parental gut feeling about illness or behavior change.
And knowing when to escalate to 911.
For all true emergencies, if the child isn't breathing properly or adequately, If their face, lips, or extremities turn blue or dusky, if they have significantly decreased responsiveness or lethargy, excessive bleeding that won't stop with pressure, or any situation the caregiver perceives as an emergency, the principle is clear. Better safe than sorry. Call 911.
And the source circles back to those laundry pods again here.
Yes. Under safe and effective nursing care, it reinforces the message about their extreme toxicity and repeats those alarming stats on pediatric poison control calls. It really underscores why this specific safety point is so critical to hammer home with caregivers during discharge teaching or well-child visits.
Got it. Constant vigilance required. Okay, finally, stepping back to the bigger picture, the source touches on something crucial we might not think about day to day, but is vital for preparedness: pediatric disaster planning.
Right. This area has seen increased focus, especially since events like 9/11. The guide highlights the unique challenges when children are involved in mass casualty events or disasters.
Such as?
Well, not all hospitals are equipped for extensive pediatric critical care needs, and weight-based medication dosing makes stockpiling appropriate supplies much harder compared to standard adult doses. Logistics are complex.
So children often need transport to specialized facilities.
Exactly. To facilities with the appropriate pediatric equipment, supplies, and trained staff. Hospitals that do care for children are required to have these resources and plans in place. It really underscores a nurse's duty to advocate for pediatric considerations and safety preparedness within any community or hospital disaster plan.
And for caregivers, what's the takeaway?
Having a family disaster plan that specifically includes the children is absolutely crucial. Knowing alternative exits from the home, having a designated meeting place outside that everyone knows, and ensuring they have important family phone numbers memorized or written down where they can access them easily in an emergency. Preparedness starts at home.
So important, but easily overlooked. Wow. Okay, that was a truly comprehensive deep dive. We covered so much ground, from those first wobbly steps and words through all those unexpected safety hazards.
Navigating tricky behaviors like tantrums and potty training,
The complexities of assessment and pain management in little ones.
and the absolutely vital role of supporting the families who are right there on the front lines every day.
Understanding these unique developmental stages, the specific risks at each age, it's just fundamental, isn't it, for providing safe, effective, and really compassionate care.
Absolutely. Whether you're a nurse, a doctor, a therapist, a teacher, or a parent or caregiver navigating these years at home, this knowledge is crucial.
So putting it all together and considering the numerous developmental complexities and all those safety risks we discussed throughout this deep dive, how can we, as a community, really incorporating the insights from this kind of resource, how can we best support both the children and their caregivers in navigating these demanding yet absolutely foundational years? It's something we're thinking about and maybe acting on long after we finish this conversation.
Indeed. These early years really do shape so much of a child's future trajectory, and that informed practical support can make a world of difference.
Catch you in the next one, goldfish crackers not included.